morning. It's lovely to be here, really. I'm thrilled. This is my first time actually at this meeting, even though I've been following the activities and progress and know some of you, but I wasn't personally here, so I'm very excited. So today's topic is, can be very complex, but it can be also easy. And what I would like to do is, in a very informal setting, present to you the difference between genetics and genomics, because we use these words and sometimes we use them interchangeably. But more importantly, without going into too much deep science and showing you all of the intracellular molecular pathways, how can we use it now? How does it help us in terms of risk assessment, prevention, and also treatment, so that we can prevent and very successfully treat breast cancer? So with this, I think this is the only little complex cartoon, but the genome, when we call the genome or the genomic structure, it actually is in the cell nucleus, and it has the genes, the chromosomes, the DNAs, everything in it. And that's a very, simple description. Of course, it's not that simple, but genes, as you know, contain material that is inherited, and that gives us certain characteristics, such as eye color, hair color, but also important for today's talk, the way we metabolize drugs, whether we are at increased risk for certain diseases, such as breast cancer, and whether perhaps we have more or less side effects to the same drug compared to other people. And these genes are made up of DNA, and they are on chromosomes. And so the whole structure is actually called the genome. Now, I want to just reiterate that we share 99% of the same genes amongst all people. Now, you know that the Human Genome Project was a major undertaking, and actually it was completed before it was planned, with the improving technology while the project was going on. So we now know the human genome, but knowing is different than, so how are we using it? What is the utility of having all of this very, 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 very detailed knowledge? So here I will summarize. This is actually a summary slide of what I will be discussing with you. And again, starting with the definition, genetics versus genomics. So when we say genetics, it's usually the genes that we are born with. We inherited these genes. Genomics, whereas, is again genes, but genes or changes in genes that happen in the tumor. So these changes are actually not inherited. They are acquired changes. So for the rest of the talk, when I say genetics, I mean inherited genes, and genomics more changes happening in the genes that are in the tumor cell. So how can we use genetics, all of the knowledge? Definitely to identify individuals that are at increased risk for certain diseases. In our case, for example, breast cancer, ovarian cancer, we call it hereditary predisposition. So we use it for risk assessment. But we can also use these inherited genes or information to help with personalized medicine, and that's a very in word right now, as you know, because we want to know if there are certain group of patients responding better to a given drug compared to other patients. As you know, traditionally, cancer therapy is, let's say, for breast cancer or lung cancer, it's the same chemotherapy, but we know that not everybody has the same response, though some people have great response. So maybe we can select good responders based on the genetic profile. And also, importantly, again, not everybody tolerates the treatments well. It doesn't have to be chemotherapy, also other endocrine therapy or the new targeted agents, as you might know, even though the toxicity profile of these new targeted smart drugs is a little bit better than chemo, they still have some side effects. So wouldn't it be great if we could find out which patient will have a side effect from drug A, so that we would give her drug B with the same efficacy, of course. So that's where we use the genetic information. Now, again, genomics, changes in the tumor, we can use in different areas as well. For example, when we look at we call it the genomic expression of the tumor, when we do use the advanced technology, we can find out what subtype of breast cancer our patient has, and that can help us understanding the natural behavior or the prognosis of that disease. And also, now there are actually several companies who are offering gene expression arrays where it helps us whether the tumor would respond to a certain drug. For example, just even groups of drugs, like is chemotherapy better in this case than endocrine therapy or vice versa, or some of the targeted agents. So it helps us with selection of the smart drugs, the targeted agents. So there's now a lot of implications of using this technology, but as I will mention and hopefully convince you that it has to be used wisely though. Just because it's out there, it's not for everyone. So again, going back to genetics now, the hereditary risk. As I mentioned, this means that we are born with these genes or gene mutations. And these genes, and let's say, the example is BRCA, very relevant to us, of course. So if there is a mutation in the BRCA1 gene, not you're only born with it and it's in the breast cells, but it's all over. It's in all of our cells has this mutated BRCA gene. And individuals who have inherited these abnormal genes or mutations show certain characteristics when cancer develops. We see early onset, for example, 20s, 30s, early 40s is when these cancers develop. What we also see is bilaterality. So bilateral breast cancer is more common when we are dealing with hereditary breast cancer. That's also true for other cancers. For example, hereditary kidney cancer, again, bilaterality is also seen more often there. The good thing is now for the last 15, 18, almost 20 years, we are able to identify these mutations, and it's clinically available in CLIA certified labs. We can identify these mutations in the blood, or actually there are even saliva kits. So for those who are afraid of blood draws, or if we want to test family members and they don't want to have blood draw, we can do a saliva test or a buccal swab, because there are cells and these cells have DNA and we can check it. As I mentioned, the mutation is everywhere in every cell in the body. So I don't expect you to read through this, and I'm not going to go through this, but this is a list of genes not only related to breast cancer. The breast cancer genes are the BRCA1 and 2, increasing risk of breast and ovarian cancer up to breast cancer up to 80%, 85%, ovarian cancer up to 45%. P10 is, for example, when we see breast cancer risk and uterine cancer risk and thyroid cancer risk. MLH1, MSH2 and 6 is another syndrome. It's ovarian and colon cancer syndrome. And, I'm not going to go down the list, but those are, we call these high penetrance genes. That means if individuals carry these mutations, then the risk of developing cancer is very high. It's more than 50%. And the reason I'm mentioning the word high penetrance is because now there are several companies that offer an array of tests where they also throw in some low penetrance genes that are not on this list. And if somebody is found to have a mutation in these genes, cancer risk is a little bit lower, and we might not exactly know what to do with those results. So we tend to try to test for the high penetrance genes, because if they're positive, then we know what to tell you and how to intervene and maybe modify the risk and decrease the risk. Now, the good news is that only 5 to 10% of cancers and breast cancers is actually hereditary. That means due to the high penetrance genes. Out of these hereditary, which is 10%, about 85% are due to BRCA1 and BRCA2 mutations. The rest, about 10 to 15%, are due to other mutations, as I've shown you, P10, P53, ATM1, PALP2, and so forth. We have a category of familial cancer, and I think a lot of you can relate to that. So we, for example, in our high-risk clinics, see patients, they are very much concerned about their family history because there are several breast cancers and they want genetic testing. But when we look at the pedigree, so the family tree, what we see is that more older postmenopausal breast cancer onset, like 60s, 70s. There are no early onset breast cancers, 20s, 30s, 40s. There's no bilateral cancer. There's no ovarian cancer. So typically, that family history tells us that it's not hereditary, it's more familial, and we might not be testing that person for these high penetrance genes. Then we have a whole other category that we call sporadic. That means it's not due to the high penetrance or the intermediate penetrance genes. It can be multifactorial. It could be, obviously age, endocrine factors such as using hormone replacement therapy, lifestyle, diet, exercise, maybe viruses, all of the other factors that I think not itself, but together with other factors when together can increase breast cancer risk. So in those cases, we really cannot pinpoint to a certain one factor. So when we are dealing with BRCA mutations, again, back to the hereditary factors, as I mentioned, breast cancer risk is very high. It's up to 88%. In fact, if we have a young woman with, let's say, stage 1 breast cancer with the BRCA mutation, her risk to develop another one in the contralateral breast, based on now 2 prospective studies, is 65%, so that's pretty high. So therefore, we actually tend to do the genetic testing at our institution, and we get a lot of referrals from our surgeons at the time of diagnosis, because some of our young patients really want to know if there is a mutation, what the risk is to develop a new cancer in the opposite breast. The affected breast can be successfully treated early stage with, nowadays with the advances in early diagnosis and screening, but she's obviously rightfully worried about the opposite breast down the line and maybe does not want to go through, again, diagnosis and treatment and chemotherapy, so she might want to do double mastectomies. So therefore, we incorporate genetic testing into the initial workup of breast cancer management. That's for our affected patients. Then obviously, we also have family members whom we test and then we find a mutation. And in those unaffected but high risk, very high risk individuals, bilateral preventive mastectomies is still an option, and we discuss it very intensely, we and then our surgical colleagues with our high-risk women. However, we tell them that there are prospective studies showing that breast cancer risk is reduced significantly by more than 95% when you undergo double mastectomies. As I mentioned, these individuals are also at increased risk to develop ovarian cancer. For BRCA2, it's about up to 25%. For BRCA1, it's up to 45%. And there is really no great screening for ovarian cancer. There is a blood marker, CA125, but it's really not long-term validated. So there's not good early screening for ovarian cancer. So those individuals are recommended to do bilateral self-finger oophorectomies late 30s, early 40s. And that reduces ovarian cancer risk by more than 95%. As a by-benefit, when bilateral oophorectomy is done in the premenopausal setting, breast cancer risk also goes down by 50%, so that's a benefit as well. And these patients or high-risk individuals are also eligible if they choose not to do preventive surgeries, MRI screening in addition to mammograms. We always tell our patients to practice breast awareness. That goes beyond self-breast exams, inspection, looking at skin changes and so forth, and then of course healthy lifestyle. Even though with mutations especially, but also other risk categories, the risk is high, I think we still can modify the risk by doing doable interventions. Diet, exercise, I think very doable modifiers. And we know that it will reduce not only breast cancer risk, but also other solid tumors, colon cancer, heart disease, cardiovascular disease, diabetes, and so forth. Hormonal replacement therapy, in my view, is also a modifiable intervention. So though some women really need hormone replacement therapy, I think there are a lot of alternatives nowadays. I think what we cannot modify given our society, and I'm actually one of them also with careers and working women, pregnancy, late pregnancies or having no pregnancies, breastfeeding can reduce breast cancer risk, for example. I think that part is modifiable. But just to know that there are things that we can do to modify our risk. And that goes not only for high-risk individuals, but also average-risk women. So whenever I give a talk to whatever the audience is, I really, really feel that when we do, especially diet and exercise, we reduce inflammation in our bodies and thereby, I think, not only breast, but other cancers also. Now, we can also use the genetics information, as I mentioned, not only to predict risk, but also response to certain chemotherapeutic or targeted agents. For example, PARP inhibitors. They are very in right now. They are found to be very effective in breast and ovarian cancers that are related to BRCA mutations. And what these agents do, they prevent DNA repair and they induce cell death of the cancer cell, because the cancer cell cannot repair its damage and it keeps dying and sort of keep proliferating. And studies have shown it's a little bit better with chemotherapy, maybe with radiation therapy, so a lot of studies are going on. And a few months ago, as you might know, an oral PARP inhibitor was approved for the treatment of advanced ovarian cancer with BRCA mutations. And the approval, I think, for breast cancer will be forthcoming as well. And these drugs have minimum side effects. And now talking about side effects, our genetic profile can also help us identifying whether we will be experiencing side effects from given drugs. For example, the hand-foot syndrome, scaling and pain and burning in the hands from capecitabine, menopausal symptoms, muscle aches and pains from tamoxifen or aromatase inhibitors, or maybe osteoporosis, because not everybody has the same side effects. I've been giving AIs for the last aromatase inhibitors for the last 10, 15 years, and there are only 3 drugs out there, but every single patient of mine exhibit different side effects. So it's not the drug, it's the way we metabolize these drugs, and that's related to the genes we have. So hopefully in the very near future, we can really pinpoint who will have bad side effects and who will not. So just to kind of summarize here, we talked about that the genetic information can help with the side effect profile and then can differentiate between good responders and maybe no responders so that we can look at some alternative. And just very briefly, the last few slides, now moving over to tumor genomics, that means the genetic changes in the tumor, not that we are born with, but the changes that happen while cancer is developing, while breast cancer is developing. And this is just a very simple example, and you don't need to be a statistician to really see that. So this is one tumor. These are the rows are the tumors, and these are the genes. So for example, this tumor's gene expression is different than this. I mean, this has more green here and red, and this is the opposite. So this technology can actually differentiate, for example, good outcome tumors from bad outcome tumors, for example. So it helps us with actually prognosis of the tumor. But it also helps us because it highlights certain pathways, inflammation pathways, angiogenesis, that means blood vessel formation pathways. And once we know that the tumor has an abnormal activity in, let's say, blood vessel formation pathways, right? That's very important because tumors need nutrition and oxygen, and while tumors are growing, they build vessels. So we want to block those vessels, and we call them angiogenesis inhibitors, for example. So these are these little molecules. This is the receptor on the cell. So these molecules block it. So like, should we use these drugs in everyone? No, we look at, certain profiles in the tumor, and I give the targeted, the smart drug to those patients who need it. And some other examples are the HER2/neu pathway, PI3 kinase. They are all in development. It's a very, very exciting era. So I want to raise the question then, the technology is out there. Is genetics and genomic testing for everyone? I think we are getting there. Call 1-800-DNA testing. So the technology is there, and it's becoming cheaper and cheaper. We were actually joking amongst ourselves. It's going to be a drive-through at CVS or Walgreens. You just do this, and somebody will poke, and or actually even a spit kit. You drive through, you spit, and then they do your genetics and genomics. it's actually possible. We are not doing it, but it's possible. The technology is there, and it's so much cheaper. I mean, sequencing the whole genome was like $50,000. Now it's less than $1,000. So, you know, it's there. But we have to think about, you know, as a society, all of us, patients, healthcare providers, policymakers, everyone, you know, ethical individuals, we all have to think about the anxiety associated with the extra information, the cost, and also, can we do something about it? We might find things where we don't know what to do yet. So sometimes the technology is racing ahead of clinical discoveries and ethical concerns, of course, and then concerns about discrimination. You know, we want to be in this situation. Though we are, with genetic testing, we have state and federal laws. In Texas, we have state law as well to prevent discrimination, but you know, we always have to be careful. So I would like to leave you with this. You know, it's out there. We want to be careful, but we want to use it very sophisticated, in a sophisticated way where we gather a lot of information and hopefully can translate the outcome to risk reduction, early screening, and great improvements in cancer treatment, breast cancer treatment, so that we can cure everyone, ER positive, ER negative, triple negative, HER2 positive, all breast cancers across. Thank you very much for your attention.